Hello, welcome everyone to this training on the Student Acuity Tool. After a great deal of engagement, the Oregon Department of Education and the Oregon School Nurses Association have partnered to create the second iteration of the Acuity Tool, which we hope is more clear and easier to use. My name is Eli Sanders, and I'm the School Health Services Specialist at the Oregon Department of Education. I am joined today by Wendy Niskanen, who is the Acting Director of the Oregon School Nurses Association. Since 2009, ORS 336.201 has required that the Oregon Department of Education, ODE, collect data related to nurse staffing and student acuity in Oregon schools. School districts are annually required to submit data to ODE, including the number of students who are medically complex, medically fragile, and nursing dependent, the number of RN FTE assigned to a single student, LPN FTE, and LPN FTE assigned to a single student. ODE compiles the data and submits an annual report to the Oregon Legislature and to the State Board of Education. This report includes the number of registered nurses and LPN FTE working in schools by district, the total number of registered nurses, nurse FTE, and LPN FTE working in schools in Oregon, the number of medically complex, medically fragile, and nursing dependent students by district, total number of medically complex, medically fragile, and nursing dependent students in Oregon, and the nurse to student ratio. School nurse staffing and student acuity data are vital for ensuring adequate healthcare supports in schools. This data helps shape policy, improve nursing services, allocate resources effectively, advocate for student well-being, and ensures equitable access to education for students with medical needs. It is critical to have effective data collection tools to encourage timely and comprehensive data that can drive and inform decision-making. Utilizing the same tool, the data that ODE reports can better help identify trends, allocate resources efficiently and effectively, improve policies, and enhance services, ultimately leading to better education outcomes for all students.
This tool is designed to reflect the student acuity as complex, fragile, and nursing dependent as they are defined in statute. These definitions are not perfect, but the data can be used to quantify, at least in part, and to reflect student need for school nursing in Oregon. This tool is used to collect data which is considered an aggregate in the annual school nursing services report in Oregon. It is not meant to measure the acuity of an individual student in order to determine the educational placement of that student. Rather, the school nurse must follow the nursing process and then participate as part of the education team, 504 or IEP, to determine the student placement. This tool and the report it supports are not designed to capture all of the work nurses do. Exploration around defining workload versus caseload for school health professionals is ongoing. It is important to be familiar with the definitions in statute. Original definitions are used in the tool, and they're located on the main page of the document. We're going to go into greater depth on these as they apply to acuity criteria while we go through the description of the tool. There are slides in this slide deck with the definitions of each category as well. General students, students with stable chronic conditions or medically non-complex students, medically complex students, medically fragile students, nursing dependent students. In this tool, there are additional definitions for what a chronic condition is, non-medical drivers of health, and care coordination. We're fortunate in Oregon to have an evidence-based toolkit on acuity on the OSNA website, which was designed by school nurses. Research tells us that using a consistent model of measurement provides objective, consistent, and sustainable data. Acuity should be quantifiable. Acuity assessment must be completed by a registered nurse. Acuity should be consider the time and complexity of nursing, including consideration of care that is accomplished by delegation, teaching, or training. All patient problems must be considered to appropriately assess acuity. Non-medical drivers of health impact complexity and acuity of an individual and their health outcomes. The link to the toolkit is here in the slide deck and on the school nurse resource webpage on the ODE website. The toolkit describes acuity and some of the purposes for which it's used, but our focus today is going to be on the components of acuity, which include chronicity, complexity of the student, psychological parameters, severity of the condition, stability of the condition, physiological parameters, intensity of nursing care, complexity of nursing care, level of dependence or participation by the client, and psychological parameters. We took these various components into consideration as we designed a tool that captured data around each one of them and intentionally develop a tool such that it does not double count aspects of acuity. Putting our work in context is important. It is the position of the National Association of School Nurses that access to a registered professional nurse all day, every day can improve student health, safety, and educational achievement. Student acuity and school community indicators should be assessed to determine appropriate staffing levels. Access to school nurses may mean that more than one school nurse is necessary to meet the needs of the school population. The tool we are using is a medical model focusing on student needs because that is the purpose of our data collection, to identify what are the students' needs for nursing daily or immediately. In Oregon, right now, this tool and eventually a validated version of it will furnish data required by the ratio law and will, if used uniformly, provide meaningful data. Though our data can have implications for establishing caseload, its purpose, defined in statute to articulate the availability of licensed practical nurses, registered nurses, and school nurses in each district, and the number of medically complex students, medically fragile students, and nursing dependent students in each school district. This tool is not designed to determine appropriate staffing because it does not measure all school community indicators, and it does not capture data on workload. Questions designed to measure acuity are student-focused, whereas questions which measure workload are school and district-focused. For example, needing to retrain staff because the student's condition has changed reflects acuity, whereas needing to repeat trainings because of workforce instability and staff turnover are workload, related to the district and the school's level of functioning. The creation of a medication plan to accommodate the specific needs of a student is student-focused and part of caseload, whereas chart audits to measure the competence of UAPs trained to administer medication are workload. The addition of and training for an emergency procedure because a student's conditions has worsened to the extent that the procedure is required is student-focused and part of caseload, whereas needing to consult with the IEP team because the student's nursing needs and goals have changed related to increased acuity is a function of the education system. So it is a task related to workload. Because the change in severity or stability is caught in the tool already, it would be redundant to add a point for attending education meetings. Developed in collaboration with ODE, in its current iteration, the Acuity tool supports a nursing assessment of multiple components of acuity. The criteria in this version are more concise and scoring scales have been fully defined. It is essential that nurses understand this tool before they use it. They should be familiar with the components of acuity as outlined in the toolkit, complete this training, study the examples below the tool, and attend acuity office hours if they need support to ensure that they understand the descriptions and use the tool consistently across the state. When used as it was designed and intended, the data collected will not be redundant and it will reflect student acuity and not workload. Let's start going through the tool. The acuity criteria are located on the far left of the tool. The previous iteration used point ranges. The undefined scales made the tool difficult for nurses to use and yielded inconsistent results. In this iteration, the scales are clearly defined to ensure nurses understand what criteria is being measured and what the scoring options are for each criteria. It is essential that nurses use the examples below the tool to ensure they understand how the scale should be used. Nurses should attend office hours if they need support to ensure they understand how to use the scales. Acuity scales are located to the right of the criteria. Nurses should not assign half points. They should consider which score is the best fit and think about which is the best criteria to capture an aspect of acuity. Throughout this presentation, we will alert you to some places where there is a risk for double counting. Please use care to prevent doing so. The point ranges were determined using a calibration process during which 34 nurses from every region of the state shared and discussed more than 120 case studies. The point ranges for each category of student are found in the bottom center of the tool. Students who score 0 are part of the general population. Students who score 1 to 2 are medically non-complex. Students who score 3 to 5 are medically complex. Students who score 6 to 10 are medically fragile. And students who score greater than 6 and score a yes on question 7 are nursing dependent. We will go through each criteria and the scale used to measure it, referring to examples and case studies beginning with chronicity. The chronicity criteria is described as the nurse has assessed that the student has one or more diagnosed chronic health conditions. Components of acuity considered in this criteria are chronicity, complexity of the student, psychological parameters. The scale of this question ensures that we capture not only those students who are complex and fragile, but also those who have a chronic condition which is not currently complex. We need to acknowledge that population which could, at a different time in other circumstances, rise to the level of complex in order to differentiate them from the general population of students. Points in the scale are assigned as follows. Score a 0 when the student does not have a chronic health condition. Score a 1 when the student has one diagnosed chronic health condition. Score a 2 when the student has more than one diagnosed chronic health condition, both managed by the nurse or has an assessed comorbidity that influences the management of the primary condition. The issue of documenting the impact on care coordination of undiagnosed mental health issues is complex because resources are so limited. It can take a long time to get access and go through a diagnostic process. Mental health conditions can be associated with behaviors. So while the student is seeking care and diagnosis, we need to use an objective measure of the impact of mental health issues. Therefore, documented ongoing behavior incidents impacting access to education and the management of conditions can be used as a comorbidity, not as a primary chronic condition. Data gathered needs to be formally collected in the school's behavior tracker system. Hearsay and stories cannot be used. A chronic condition is a disease or condition that usually lasts for 3 months or longer and may require professional nursing services to ensure access to education or limit activities of daily living or both. This includes conditions with intermittent flares or lifelong diagnoses. This question does not collect data about acute conditions. Do not include acute conditions such as concussion, significant injuries, or extended illnesses such as mononucleosis. If concussion persists and is diagnosed as post-concussion syndrome or traumatic brain injury, it can be included as a chronic condition. So what does this look like in practice? When there is one condition, score 1 point, even if the condition is not currently managed by a nurse. This will ensure that we can capture the medically non-complex students. Historically, reporting of medically complex, fragile, and nursing-dependent students has represented 4 to 6% of student enrollment. Educators assume that all of the rest of the students are part of the general population. We know that anywhere between 18 and 25% of students have chronic conditions, and this is the criteria where we need to document those medically non-complex students. Currently, we do not report these students to ODE, but we should use this tool to begin to document them. We have established that concussion should not receive a point, but traumatic brain injury would merit a point. More than one behavioral health diagnosis is considered one condition because the management of them will be in one plan of care. For example, there would not be a separate plan of care for anxiety and depression. Care not related to medical diagnosis should not be captured in this tool. For example, if a student needs care, which is related to a behavior and not associated with diagnosis, it should not be captured here. For example, a young kindergarten student needing support around toilet training because they have not mastered the skill yet, but is not related to a medical condition, does not have a chronic condition. Whereas a student with encopresis related to a medical or psychological diagnosis would be considered to have a chronic condition. If the student has a distant history of a condition which is no longer managed by medical providers, it should not be captured in this tool. A student who is complex with significant limitations for whom the nurse only manages one condition and the other conditions are not comorbid. For example, a student with cerebral palsy, dyslexia, and type 1 diabetes, in whom the cerebral palsy and dyslexia do not complicate medical management of the type 1 diabetes, would score a 1 in chronicity. If there is more than one diagnosis, in order to score 2 points on this criteria, one of the following must be true. Either the nurse is actively managing both conditions, for example, asthma and anaphylaxis or diabetes and seizure, or the nurse is managing one condition which is impacted by comorbidity with another condition. In this criteria, we can capture the impact of mental health diagnoses on the complexity of a student. For example, anxiety can impact the management of asthma when anxiety is a trigger for asthma. A student with an intellectual disability which limits glycemic awareness and communication would complicate the management of type 1 diabetes. Now we're going to move into the second criteria measured, which is severity. Severity criteria is described as the nurse has assessed the extent to which the condition has the potential to become life-threatening. The components of acuity considered in this criteria include severity and level of participation. Points in the scale are assigned as follows. Score a 0 when the student is not at risk for a life-threatening event. Score a 1 when the student is at risk for a life-threatening event but is typically stable. Score a 2 when the student is at risk for a daily life-threatening events. This question is challenging because, as school nurses, so much of our focus is preparing for the worst-case scenario, so staff will respond effectively. Many students are at risk for a life-threatening event. This question asks nurses to report the relative risk. Referring to the examples below the tool will support consistent responses in the scale of this criteria. First, it is important to differentiate between what is life-threatening and what is life-limiting. A student can have a terminal illness but not be at risk on a daily basis for a life-threatening event. Consider the medical mechanism for the event, and this will help you determine the relative risk. Recognize that the nurse should be assessing the student in the present, not over the course of several years. The nurse should ask, what does the data collected this year tell me? Next, consider the data to inform your decision about the student's relative risk for life-threatening events. What are the manifestations of the condition? Is blood glucose stable? Are there breakthrough seizures? Is there a history of severe adverse events such as static epilepticus or hospitalizations for DKA? What is the student's level of self-management and participation in self-care, including awareness of the condition and capacity to support positive outcomes by managing their condition? Does the student have awareness of allergens and triggers and/or the capacity to avoid them? How is the family's compliance and what is their capacity? Do they remember controller medications for asthma, or is there a system in school for a missed dose? Are the rescue medications provided for the school? Does the family understand and have the capacity to manage type 1 diabetes proficiently? Are there environmental actors impacting their risk? Are there allergens or triggers present? Double count alert. Note, With additional care coordination, the school nurse can mitigate some of the risk. In that case, the score for severity would be lower and data on additional care coordination would be captured later in the tool. Throughout this presentation, we will be sharing examples which illustrate how the scales are defined and how they are to be used. Examples will come from the guidance below the tool and from some case studies we will discuss later in the session. Consider a student with severe allergic reaction. Exposure to allergen will cause anaphylaxis in the student, but not all students with a plan to manage severe allergic reaction will measure a 2 on this scale. The risk of an event at school varies due to several factors. The prevalence of allergen varies from an uncommon allergen unlikely to be present in the school environment, to a single allergen which may be present in select school settings, to multiple allergens and/or an allergen found in many sources such as soy or latex that is common in the school setting. The likelihood of anaphylaxis also can be impacted by a student's understanding about the coordination and ability, about the condition and their ability for self-care. A student unable to recognize an allergen and effectively carry out plans to avoid it is at far higher risk than one who is aware and capable of avoiding the allergen. Now consider a student with seizures. The relative risk for a student with a distant history of seizure diagnosis who no longer takes controller or cessation medication and is no longer followed by a neurologist is lower than a student with a seizure diagnosis who experiences breakthrough events. Alternatively, a student who has intractable seizure activity despite seizure cessation medication and a history of status epilepticus or respiratory distress or failure connected to seizure events will be at higher risk. Consider also if the student recognizes and can avoid triggers. Consider a student with type 1 diabetes. It would be unlikely that a student with type 1 diabetes would score a 0 as having no risk at all for life-threatening events. Rather, an assessment would determine if the student is at risk but typically stable, perhaps with well-controlled diabetes, stable blood glucose levels, with consistent insulin orders, and/or is a successful independent self-manager. Or is the student at risk for daily life-threatening events presenting with labile blood glucose, frequent insulin order changes, and/or experiencing episodes of extreme hypoglycemia requiring glucagon or hyperglycemia related to DKA. Next, we're going to move on to the next criteria, planning and assessment. The planning and assessment criteria is described as the nurse has assessed that the student requires an individual plan of care to manage a chronic condition. The components of acuity assessed by this criteria include stability, intensity, and physiological parameters of the condition. Points in this scale are assigned as follows. Score a 0 when no individual plan of care is in place. Score a 1 when an individual plan of care is in place, but minimal nursing assessment and management are expected to manage routine care. Score a 2 when an individual plan of care is in place. Intermittent nursing assessment and management throughout the school year is expected. This includes routine delegation supervision or routine dependent diabetes management. Note, twice in a year is not intermittent. Score a 3 when an individual plan of care is in place and daily high-frequency nursing assessment and direct nursing management are required. Plans of care are called by various names: individualized health plan, health management plan, health guidelines, swallower feeding protocols, medication plans, safety plans. But all must be developed using the nursing process. They must exhibit clinical judgment and contain interventions. Clinical judgment is defined in the Nurse Practice Act as the observed outcome of critical thinking and decision-making. It is an iterative, repetitive process that uses nursing knowledge to observe and assess presenting situations, identify, prioritize client concerns, and generate the best possible evidence-based solution to deliver client care. Plans of care do not include plans created by other health professionals, such as a safety plan created by a crisis team at a mental health organization, or authorization and permission forms alone without a medication plan, or building emergency plans such as evacuation or fire drill protocols. Medication administration authorization paperwork alone does not meet the requirement of a plan of care. For example, a student who takes allergy medication as needed for symptom management from seasonal allergies who has only authorization papers would not be considered as having a medication plan. Similarly, a student with ADHD who is well controlled with a scheduled dose of medication for whom there is no additional planning and for whom we only have authorization forms would not be considered as having a medication plan. On the other hand, planning for medication administration to a student with intractable ADHD for whom the dose is being titrated, which requires critical thinking by the nurse, constitutes a medication plan. The routine surveillance done to follow up on medication administration training, which is general population workload, is essential for student safety and extremely time-consuming. However, it measures staff competence, not the acuity of a specific student. Consider the student with well-managed ADHD. A staffing change, such as hiring a new secretary, might require retraining and/or result in medication errors. This change does not reflect an increase in student acuity. The location of the nurse is not relevant for this question. Practice model decisions, such as whether or not to delegate as a rule, not determined on a case-by-case basis, should not be measured in this tool. Those decisions are practice or systems decisions and do not reflect the acuity of a specific student. For example, the routine management of students with diabetes requires completion of daily tasks which follow a plan of care and can be rote. Though the nurse may need to respond to questions, they are present to complete tasks. Ongoing assessment is not regularly required. The student would be measured as a 2 for this criteria, whether a practice model dictates that the nurse is present or has delegated the care. However, a student whose diabetes is comorbid with an intellectual or developmental disability or who is nonverbal presents with a need for ongoing nursing assessment because the student cannot recognize and or report glycemic events. That student would measure a 3 for this criteria. Let's look at some examples of planning and assessment for a student with type 1 diabetes. There is rarely a time when no planning is required to manage a student with type 1 diabetes in school, so it is unlikely that the planning and assessment score of a student with type 1 diabetes would be a 0. If the student successfully manages type 1 diabetes independently and beyond the nursing process to implement a plan of care, the nurse is rarely consulted, the score would be a 1. If the student with type 1 diabetes requires supervision and assistance with interventions and requires intermittent nursing assessment and/or updates to the plan of care, the score would be a 2. If the student's condition requires ongoing nursing assessment, for example, because the student cannot recognize or articulate glycemic events, the score would be a 3. Let's consider examples of planning and assessment for a student with asthma. If the student has a history of asthma symptoms, but the student no longer requires monitoring or medical management, the score would be a 0. If the student has a current asthma diagnosis which is well managed, and beyond the nursing process to implement a plan of care, the nurse would be rarely consulted, the score would be a 1. If the student's asthma is not well controlled and the condition requires nursing assessment and/or updates to the plan of care, the score would be a 2. If the student's condition requires nursing assessment frequently, for example, because they have a history of respiratory failure due to asthma exacerbation, the score would be a 3. Let's look at examples of planning assessment for a student with a seizure disorder. If the student has a history of seizure disorder, of a seizure diagnosis, such as a history of infantile febrile seizures, which no longer require monitoring or medical management, the score would be a 0. If the student has a seizure disorder which is well controlled by medication with no recent history of breakthrough seizures and beyond the nursing process to implement a plan of care the nurse is rarely consulted, the score would be a 1. If the student's seizure condition requires intermittent nursing assessment and/or updates to the plan of care, the score would be a 2. If the student's condition requires nursing assessment continuously, for example, because the student has a history of status epilepticus or loss of an airway during a seizure, then the score would be a 3. Let's apply the assessment of this criteria to case studies. Luke is a second grader who takes daily ADHD medication administered by medication-trained staff. Luke has an IEP, but there are no nursing or health services supports listed. Student has a medication administration authorization forms only. He does not have a plan of care. The severity scale or risk of life-threatening event is a 0, and the planning assessment scale would be a 0. Henry is a sixth grader who takes 2 medications for ADHD at school. He is resistant to taking the medications. The nurse has created a plan of care with teachers and office staff to help with compliance. The nurse consults with parents and students regularly. Henry has an IEP and nurse consultation is listed as a support for school staff. The severity scale for the student would be a 0, and the planning and assessment scale for the student is a 2 because the nurse is intermittently consulting. The next criteria is emergency procedure. The emergency procedure criteria is described as the individualized plan of care includes an invasive step-by-step emergency procedure for a potentially life-threatening event. Components measured in this criteria include severity and intensity. Points in this scale are assigned as follows. Score a 0 when no individual emergency procedures are required or trained for. Score a 1 when individual emergency procedures are in place. A provider order for a rescue medication is needed, and the prescribed medication for the individual student must be present to score a 1 in this criteria. An emergency plan which lists the steps to take while awaiting 911 is not considered an emergency procedure. For example, covering a G-tube stoma after accidental dislodgement. A plan to perform an intervention, such as reinserting a tracheostomy tube in the event of an emergency, is considered an emergency procedure. Frequency of utilizations of the emergency procedure is not considered in this question. Utilizing a nebulizer for standard asthma care does not qualify as a rescue procedure. Some examples, and this list is inclusive: VNS, rescue seizures or medications, epinephrine administration, glucagon administration, injectable steroid for adrenal insufficiency, G-tube replacement, tracheostomy tube reinsertion, unscheduled emergency nebulizer treatment. If a point, double counting alert. If a point is indicated here for an emergency intervention, do not award a point for the same tasks in line 5 for complexity. Again, we will apply this scale to case studies related to type 1 diabetes. Steve is a 5th grader diagnosed with type 1 diabetes 4 years ago. Bacemi is in the health room. Emergency procedure score is a 0. Kevin is a 10th grader with type 1 diabetes. Although glucagon is listed on the physician's school orders, his parent had not provided it for school. It is not present for training, so the emergency procedure score is a 0. Let's look at case studies related to severe allergic reaction. Lily is a 3rd grader with anaphylaxis to peanuts. She has an EpiPen Junior in the health room. She knows to avoid nuts and eat school in the lunchroom. A plan of care is in place. The severity score is a 1 because there is some risk of a life-threatening event. The planning and assessment score is a 1 because there is a plan of care in place, but the nurse does not have to intermittently go back around and do assessments. The emergency procedure score is a 1 because there is an EpiPen Junior in the health room. Nolan is a third grader whose parent documented a severe peanut allergy on his enrollment forms. The parent has not provided epinephrine for the health room, and there is no other documentation about his allergy other than the parent report. Even though the RN has limited information about Nolan's individual needs, a plan of care was developed. In this case, the nurse would do an assessment of the student and take a history to determine the veracity of the medical condition. In this case, the severity score would be a 0. There is no evidence that there is possibility for a life-threatening event. The planning and assessment score is a 1. The nurse chose to put a plan in place, and there is a 0 score for emergency procedure because there is no emergency medication in place. Case studies related to asthma. Cassie is a 5th grade student with asthma. A rescue medication is in the health room. A rescue inhaler is in the health room, which Cassie uses infrequently at school. The nurse assesses the student and updates the plan of care yearly to manage the condition. The severity score is a 1, the planning and assessment score is a 1, and the emergency procedure score is a 0. A rescue bronchodilator is not considered an emergency medication. Deona is a 2nd grader who has moderate persistent asthma. She uses an inhaled corticosteroid medication every day at home to prevent asthma episodes. She has a bronchodilator inhaler at school that she uses before PE and is needed, typically once every other week. When Deona is ill, she frequently has asthma flares for which she has been hospitalized twice during this school year. To manage symptoms of respiratory distress, nebulized albuterol is prescribed, for which the father has provided a nebulizer and medication for school. The severity score is a 2, the planning and assessment score is a 2, and the emergency procedure score is a 1. Note that the nebulizer here is being captured because it is used as an emergency medication for respiratory distress, not for the management of routine asthma symptoms. We're going to move on to the criteria of complexity. The criteria of complexity is described as the individual plan of care includes detailed, step-by-step invasive procedures to meet the student's routine daily health needs. The components measured in this criteria include complexity of the student, complexity of nursing care, and intensity. Points in this scale are assigned as follows. Score is 0 when a student requires no complex procedures. Score 1 when the student requires one multi-step procedure that is performed routinely, including the same single procedure performed multiple times daily. Score 2 when the student requires more than one multi-step procedure or a single procedure which may necessitate adjustments to the routine process based upon collected data. This criteria can reflect a student's level of self-management and participation in self-care, their awareness and capacity. Procedures being managed by another entity, such as a personal care worker or a home health agency, do not receive points for this criteria. For example, the management of a medication port not utilized in school would not be captured in this criteria. Double counting alert. Tasks in this list are repeated routinely daily. Procedures reported in the previous question on emergency procedures should not be double counted here. Examples include clean intermittent catheterization, G-tube management, diabetes management, nebulizer for routine care, not for rescue medication. Examples. The nurse might score this criteria for student with type 1 diabetes if the student is independent with respect to the management. The score would be a 0. However, if the nurse or delegee is providing supervision and verification only because the student is a self-manager but is not completely independent, the score would be a 1. If the student is completely dependent for assistance on staff for all aspects of diabetes care, the score would be a 2. Let's look at some case studies related to G-tube, to case studies related to type 1 diabetes. Hazel is a first grader who was diagnosed with type 1 diabetes 2 months ago. Her blood glucose levels fluctuate. Hazel requires direct assistance with all diabetes management, including finger sticks, carb counts, high and low treatments, injecting insulin with a pen, and ketone testing. Hazel's complexity score would be a 2. The nurse has assessed that Steve is competent in all aspects of self-managing his diabetes. However, the provider has stipulated supervision is required. Trained staff oversee insulin dosing twice a day before breakfast and lunch. So the complexity score for Steve would be a 1. Kevin is a 10th grader with type 1 diabetes. He is independent with all aspects of diabetes management, although he has come to the health room if he is low and forgets fast-acting carbs and snacks. He wears a CGM. His complexity score is a 0. Let's look at some examples of complexity for a student with a G-tube. If the nurse puts only an emergency protocol for an accidental removal, and that protocol does not include replacement of the G-tube is not used during school hours, the score would be a 0. If the G-tube is used for regular feedings, where the amounts of water for flush and food do not vary, and the student tolerates the feeding well, the score would be a 1. If the G-tube requires any of the following: intermittent venting, feedings are not well tolerated, so the amounts of food vary. If the G-tube is used to administer medication, the score would be a 2. Let's look at some case study examples related to G-tube. Xanta is a student with cerebral palsy who uses a wheelchair, has a seizure disorder, and receives all nutrition and hydration by gastrostomy tube. At school, she receives 2 feedings of formula followed by a 20 cc water flush. The procedure is stable and predictable, and the RN has delegated it to UAPs. The complexity score would be 1. It's the same routine task repeated. However, Evelyn is nonverbal. She has a G-tube and gets supplemental formula and water only if she does not consume enough orally. She requires intermittent venting daily. The RN has trained UAPs to administer seizure medication and provide physical support, but a nurse manages Evelyn's feeding and related management because of the unpredictable nature of her G-tube needs. The complexity score would be a 2. If a student comes to school with a running pump and no one is managing that procedure in school, that student might score a 0 in this criteria. Whereas, if a student has a routine pump feed which is managed in school, initiated, monitored, or completed, the score would be a 1 in this criteria. Next, we're going to move on to the criteria of non-medical drivers of health. Non-medical drivers of health are defined as the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. According to the Healthy People 2030 report, these variables can be grouped into 5 domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Specific examples in schools include transportation, food, and housing insecurity. Non-medical drivers of health can impact a student's health maintenance or potential risk for complications, such that an increased care coordination, including but not limited to facilitating medical appointments and/or access to medical supplies, is needed to ensure the student can access education. This criteria was a challenge to define because so many students are impacted by complex social histories, poverty, and its sequelae. That non-medical drivers of health impact health outcomes is clear, and yet the challenge of objectively measuring their impact on the need for school nursing is profoundly difficult. This tool is designed to measure and report student acuity for the purpose of reporting nursing availability and the need for Oregon schools. To this end, this question will document increased care coordination facilitated by the nurse in response to non-medical drivers of health and with the aim of mitigating these risk factors that are posed for the students. It is important to name, even if this tool cannot quantify it, school nurses' compassion and caregiver fatigue, which can result from supporting populations facing catastrophic difficulties. We acknowledge the impact of non-medical drivers of health on school nursing practice while recognizing that we are not measuring that impact here. Non-medical drivers of health criteria is described as the student's health maintenance or potential risk for complications are impacted by one or more non-medical drivers of health, resulting in an increased need for care coordination to ensure the student can access education. The components of acuity measured in this criteria include psychosocial parameters, complexity of the student, complexity of the nursing care, and intensity. Points in the scale are assigned as follows. If the student's need for care coordination is not significantly impacted by non-medical drivers of health, the score would be a 0. If non-medical drivers of health are assessed as impacting health maintenance and or potential risk for complications such that the additional care coordination was required, the score would be a 1. To select a 1 on this criteria of acuity, a nurse must have documented care coordination interventions which extend above and beyond the typical management of a student in the school setting. Document the increase in care coordination regardless of the success of the interventions. Interventions of care coordination include facilitating appointments, and that might mean making the appointment or arranging for transportation, facilitating access to supplies, whether they're disposable and or durable medical, facilitating access to medication. An important counting note. If there is no emergency seizure medication related to a non-medical driver of health, a point for non-medical drivers of health should not be awarded here. Additionally, a point for emergency procedures for that medication should not be indicated. However, if the nurse provides additional care coordination attempting to get the medication, a point would be indicated here. If the nurse did not obtain the medication, a point for emergency procedures for that medication would not be indicated. If the nurse provides the additional care coordination and obtains the emergency medication and subsequently trains staff on the usage of the medication, points would be scored for this criteria and for the emergency procedure criteria. Double counting alert. Consider a student who has a recent history of hospitalizations for asthma exacerbations during the immediately past summer, likely due to the family's non-compliance with controller medication. A nurse provides additional care coordination and plans to administer the controller medication in school, which is not typically done, and no further incidents requiring hospitalization result. The nurse would score a 1 to document the care coordination. The nurse might have considered a severity score of 2 because the student was assessed to be at high risk of daily life-threatening events. However, if the severity was mitigated by the additional care coordination, the nurse might reduce the severity score to a 1. Let's look at some case studies for non-medical drivers of health. Bradley's wheelchair needs to be replaced, but private insurance won't pay for it. Twice during the school year, the brakes broke and he missed school because transportation would not transport him on the bus until they were fixed. The nurse regularly assists with care coordination, including interacting with the vendor for the wheelchair, so that he can access his education program by providing community supports, coordinating appointments, and checking in with parents. The non-medical driver of health score would be a 1. Xanta is a student with cerebral palsy who uses a wheelchair, has seizure disorder, and receives all nutrition and hydration by gastrostomy tube bolus. Xanta's parents speak Spanish, and they do not have a vehicle. Xanta's family members, their extended family, are able to provide transportation when needed. The RN is able to effectively communicate and coordinate care with the mother through an interpreter. So the non-medical driver of health score would be a 0. Additional care coordination is not needed by the nurse because the systems are making the student have access to education. Double counting alert. Consider a student whose only nursing need is requiring an injection in school, which is not typically provided by school staff such as Lovenox. This care could be noted in a medication plan of care, or it could be noted here as an example of additional care coordination beyond what is typically provided in school. It should not be noted in both places. The next criteria we're going to consider is dependency. The criteria is necessary to ensure that acuity ratings align with statutory definitions. The level of dependence criteria is described as, does the student require daily, direct, continuous nursing care? In other words, does the student being assessed meet the statutory definition for nursing dependent? Points in this scale are assigned as followed. If the answer is no, the student is not nursing dependent. If the answer is yes, and the student requires an assigned one-to-one nurse while at school to manage health needs throughout the school day, the answer is yes. A finding of nursing dependence should be reported with supporting data to the IEP team for final determination of staffing. The care for a student who is nursing dependent is so continuous that the nurse requires coverage for any breaks. We have used parts of the following case studies throughout this training to make assessment of the whole case easier to complete. Xanta is a student with cerebral palsy who uses a wheelchair, has a seizure disorder, and receives all nutrition and hydration via gastrostomy tube. At school, she receives 2 feedings of formula followed by a 20 cc water flush. Procedure is stable and predictable, and the RN has delegated it to UAPs. Xanta experiences scattered brief seizure activity, especially when she is startled. She does not have a history of status epilepticus and does not have seizure rescue medications at school. The IEP and plan of care are in place. Xanta's family speaks Spanish and does not have a vehicle. Their extended family members provide transportation when needed. The RN is able to effectively communicate and coordinate care with the mother through an interpreter. The score for chronicity is 2 because there is more than one condition being managed by the nurse. The score for severity is a 0 because the student is not at risk for a life-threatening event. Planning and assessment score is a 2. There is a plan of care in place, and the nurse is providing intermittent nursing assessment and management throughout the school year. The emergency procedure score is a 0. The complexity score is a 1 because the student's tube feeding is routine, stable, and predictable. The non-medical driver of health score is a 0. The student is not nursing dependent. With a total of 5 points, the student is medically complex. Bradley is a 10th grade student who has a chromosomal disorder. He has asthma, a gastrostomy tube, and a tracheostomy. His asthma is well controlled at school, but flares when he is ill. He was hospitalized over winter break because he has a history of GERD. His feedings during the school day are delivered by a pump. The formula is mixed with water before administration. He receives medication at school daily through his G-tube. Bradley requires intermittent tracheal suctioning throughout the school day. Parent has health issues and often misses doctor appointments. Although the student has private insurance, it doesn't pay for all his medical needs. His wheelchair needs to be replaced, but private insurance won't pay for it. Twice during the school year, the brakes broke and he missed school because transportation wouldn't transport him on the bus until they were fixed. The nurse regularly assists with care coordination so that Bradley can access his educational program by providing community supports, coordinating appointments, and checking in with parents. Bradley has an IEP and receives one-to-one nursing care to meet his health needs in the classroom and on the bus. A plan of care is in place and includes tracheostomy replacement in the event of accidental decannulation. The score for chronicity is a 2. There is more than one condition managed by the nurse. Severity is a 2. The student is at daily risk for life-threatening events. Planning and assessment is a 3. An individualized plan of care is in place. Daily high-frequency nursing assessment and direct nursing management are required. Emergency procedure score is a 1. Recannulation plan is in place. The complexity score is a 2. The student has multiple procedures, G-tube feed, and tracheal suctioning. The non-medical driver of health score is a 1. The nurse assists with coordinating appointments and wheelchair maintenance. The student is dependent. So with a score of 11 and a yes on the final question on dependence, the student is assessed to be nursing dependent. Evelyn is a student who has Rett syndrome manifesting in a seizure disorder and the need for gastrostomy tube. She uses a wheelchair and is nonverbal. She has about 10 seizures per month at school and requires rescue medications about once a month for seizures that last over 5 minutes. She eats orally and requires an adult to feed her, has a feeding protocol in place because she is at risk for choking and aspiration. She has a G tube and gets supplemental formula and water if she does not consume enough orally. She requires intermittent venting daily. The registered nurse has trained the UAP to administer seizure medication and to provide physical support, but a nurse manages Evelyn's feeding and related management because of the unpredictable nature of her needs. The IEP and plan of care are in place. The score for chronicity is a 2. There is more than one condition being managed. Severity score is a 2. The student is at daily risk for life-threatening events. The planning and assessment score is a 3. An individual plan of care is in place and daily high-frequency nursing assessment and direct nursing management are required. The emergency procedure score is a 1. Seizure cessation medication is in place. The complexity score is a 2. The student's G-tube feed needs adjustment, and the non-medical driver of health score is a 0. The student is not dependent. With a total score of a 10, the student is medically fragile. Ellie is a 5th grade student who was born with myelomeningocele spina bifida and has associated diagnosis of hydrocephalus and neurogenic bowel and bladder. She uses a wheelchair for mobility. A VP shunt was surgically placed after birth to treat hydrocephalus, and she requires clean intermittent catheterization twice during her school day. The registered nurse has provided training to staff about what to watch for shunt malfunction and steps to take if it occurs. The RN has delegated the CIC procedure. A plan of care is in place. The score for chronicity is a 2 because there is more than one condition being managed. The score for severity is 1. The student is at risk for life-threatening events but is typically stable. The planning and assessment is a 2. An individual plan of care is in place. Intermittent nursing assessment and management throughout the school year is expected. Emergency procedure is a 0. The complexity score is a 1. The student's CIC is routine. Non-medical drivers of health score is a 0. The student is not dependent. With a total score of 6, the student is medically fragile. Hazel is a 1st grader who was diagnosed with type 1 diabetes 2 months ago. Her blood glucose levels fluctuate and she is unaware of feelings of low or high blood sugar. Hazel requires direct assistance with all diabetes management, finger poke, carb counting, high and low treatment, insulin injection with a pen, and ketone testing. The registered nurse has trained staff in all areas, but the registered nurse does insulin injection. The staff call the nurse regularly for direction. A plan of care is in place. Bacsemia is in the health room. The score for chronicity is 1. There is only one condition being managed by the nurse. Severity is a 2. The student is at daily risk for a life-threatening event. The planning and assessment is a 2. An individual plan of care is in place. Intermittent nursing assessment and management throughout the school year is expected. The emergency procedure score is a 1 because bacsemia is in place. The complexity score is a 2 because all aspects of diabetes management are managed by staff. The non-medical drivers of health score is a 0. The student is not dependent. With a total score of 8, the student is medically fragile. Steve is a 5th grader diagnosed with type 1 diabetes 4 years ago. His condition is typically stable, although he experiences some occasional low and high blood sugar levels, which he manages well on his own. He has an insulin pump and a CGM. The nurse has assessed that Steve is competent in all aspects of self-managing his diabetes. However, the provider has stipulated supervision is required. Trained staff oversee insulin dosing twice a day before breakfast and at lunch. Staff call the RN for support when needed. A plan of care is in place. Bacsemia is in the health room. The score for chronicity is a 1. There is only one condition being managed by the nurse. Severity is a 1. The student is at risk for life-threatening events but is typically stable. The planning and assessment score is a 2. An individual plan of care is in place. Intermittent nursing assessment and management throughout the school year is expected. The emergency procedure score is a 1. Bacsemia is in place. The complexity score is a 1. The staff is only supervising one task. There is a 0 score for non-medical drivers of health. The student is not dependent with a total score Of 6, the student is considered medically fragile. Kevin is a 10th grader with type 1 diabetes. He is independent with all aspects of diabetes management, although he has come to the health room if he is low and forgets fast-acting carbs and snacks. He wears a CGM. Although glucagon is listed on the physician orders for school, his parent has not provided it for school. The score for chronicity is a 1. There is only one condition managed by the nurse. Severity is a 1. The student is at risk for life-threatening events, but is typically stable. Planning and assessment score is a 1. An individual plan of care is in place, but minimal nursing assessment and management are expected to manage the routine plan of care. Emergency procedure is a 0 because the rescue medication is not provided. The complexity score is a 0 because the student is performing all aspects of his own care. Non-medical driver of health score is a 0. Student is not dependent. With a total score of 3, the student is medically complex. Considerations around acuity assessment. When the student leaves a district before the acuity report is submitted at the end of the school year, that student should not be included on the sending district's report. The student can be included in the receiving district's report if the student stays in Oregon. Appropriate transfer of education records when the student remains in state will ensure the data point is not lost. An education records request includes school health records. So making an effort to call or email for transition and continuity of care is appropriate. Reporting period for acuity is late in the spring. Assessment can be ongoing. Please look at the School Nurse Research webpage for more information. OSNA will be open for support implementing the tool during office hours. Currently, they are happening at 1 o'clock on Wednesdays to answer questions. We're also available to work with groups of nurses at specific districts. Please reach out if you have any other questions, and thank you so much for attending this training.